Crohn's disease. Crohn's disease is a type of inflammatory bowel disease characterized by chronic, relapsing inflammation of the gastrointestinal tract. It can affect any part of the GI tract from the mouth to the anus, most commonly in the terminal ileum. Unlike ulcerative colitis, the inflammation in Crohn's disease is transmural, involving all layers of the bowel wall, and often discontinuous, aka skip lesions. Peak incidence. There is a bimodal distribution of Crohn's disease. The primary peak occurs at 15 to 30 years old. The secondary peak occurs 60 to 80 years old. Slightly more common in females and in individuals of Ashkenazi Jewish descent. Pathophysiology. The exact cause is unknown, but genetic susceptibility, for example NOD2 mutations, dysregulated immune response, gut microbiota, and environmental factors contribute. Chronic inflammation causes transmural damage, leading to ulcers, strictures, fistulas, and granuloma formation on histology. Disease is segmental, with skip lesions and intervening normal mucosa. Symptoms: chronic diarrhea, often non-bloody. Right lower quadrant abdominal pain. Weight loss and malnutrition. Fatigue. Fever, inactive or severe flares. And perianal symptoms, for example pain, discharge, fistulas. Signs: abdominal tenderness, especially in the right iliac fossa. Palpable mass from thickened bowel or abscess. Perianal disease. This includes fissures, skin tags, abscesses, and fistulas. Oral aphthous ulcers, and clubbing from chronic inflammation. Extra-intestinal manifestations include skin, erythema nodosum, pyoderma gangrenosum, joints, arthritis, axial and peripheral, eyes, uveitis, episcleritis, and hepatobiliary. This includes gallstones and primary sclerosing cholangitis. This is less common in Crohn's than ulcerative colitis. Diagnosis: first line, fecal calprotectin. This is a highly sensitive marker of intestinal inflammation. Gold standard, colonoscopy with biopsy, if patient is stable. This will show skip lesions, cobblestone appearance, transmural inflammation, non-caseating granulomas, and increased goblet cells. Further investigations. Blood tests. Full blood count could show anemia. CRP and ESR can reflect inflammation. Vitamin B12 and vitamin D should be done because there may be deficiency due to malabsorption. Anti-TTG antibodies to rule out celiac disease. UNEs and LFTs. Stool tests. Stool culture and microscopy to exclude infective causes. Imaging. MRI enterography. This is preferred for assessing fistulas and strictures. CT abdomen pelvis for acute complications, for example abscess. And barium studies. This is less commonly used but may show strictures, string sign. Complications. Strictures, which can cause bowel obstruction. Fistulas, which can be enteroenteric, enterocutaneous, rectovaginal, which is the most common fistula site. Perianal disease, which may have abscesses, fissures, fistulas. Osteoporosis, due to inflammation, corticosteroids, and malabsorption. Colorectal cancer, which is an increased risk with long-standing disease. Nutritional deficiencies, iron, B12, folate, fat-soluble vitamins because of malabsorption, growth delay in children, and psychosocial impact, depression, anxiety, and reduced quality of life. Management. Acute flare. Glucocorticoids are first line. Oral prednisolone or IV hydrocortisone. Budesonide for mild ileocecal disease. 5-ASA, for example mesalazine. This is less effective in Crohn's than ulcerative colitis, but may have limited role in mild colonic disease. Immunomodulators, for example, azathioprine, mercaptopurine, not for induction alone, but added to maintain remission. Methotrexate is an alternative for thiopurine intolerant patients. Biologics. Anti-TNF agents, infliximab, adalimumab, for refractory disease or steroid-dependent patients. Consider in perianal Crohn's or frequent exacerbations. Antibiotics. Metronidazole for isolated perianal disease or abscesses. Enteral nutrition, first line for induction in pediatric patients, may be used in adults to avoid corticosteroids. Maintenance of remission. Lifestyle. Smoking cessation, this is strongly advised. It can worsen Crohn's disease. First line, azathioprine or mercaptopurine. Second line, methotrexate. In refractory cases, biologic therapy. Surgical management. Up to 80% of patients require surgery over their lifetime. This is not curative. Recurrence is common at the anastomotic site. Indications for surgery include strictures causing obstruction, fistulas or abscesses not responding to medical therapy, perforation or toxic megacolon, severe perianal disease, and failure of medical therapy. Surgical options include segmental small bowel resection, stricturoplasty, which preserves bowel length, proctectomy in severe perianal Crohn's, and ilioanal pouch, not recommended because of a high risk of failure. Perianal disease. Oral metronidazole for symptomatic relief. Anti-TNF therapy, for example infliximab for fistula healing. Draining set-on placement for complex fistulas. This prevents abscess formation and premature closure. Perianal abscess. This requires incision and drainage. Consider prophylactic antibiotics in high-risk cases. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today